Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. There has long been a link between hearing loss and cognitive decline in older adults. A new study led by Johns Hopkins researcher Dr. Frank Lin finds that providing hearing aids and other interventions to people over 70 who are at risk of thinking and memory problems can dramatically slow the rate of mental decline. Stephanie Desmon talks to him about his new research. Let's listen.
Frank Lin, thanks so much for joining me.
Thanks for having me, Stephanie.
So you have an exciting new study in The Lancet about hearing loss and cognitive decline, and I'm wondering if you could tell us about it.
This has been a long time coming, and what I mean by that is for over a decade now, research that we've been doing here at Johns Hopkins as well as elsewhere has increasingly been making a case for how we understand how hearing loss can really impact dementia risk. And importantly, based on epidemiological studies over the last several years, that in fact hearing loss may in fact be the largest contributor to dementia out of all known risk factors. But that's great. It's academically interesting. But fundamentally, the question then, of course, everyone cares about then is that what does that mean if we actually treat hearing loss in older adults? Does that in fact reduce the cognitive decline as well as possible risk of dementia? That's always been unknown because there's never been a randomized controlled trial until now.
So tell us about the study.
Yeah, so this is a study that we first started back in late 2017. It's a trial that involved nearly 1,000 older adults around the U.S., recruited at 4 different field sites around the U.S. And these adults are all between 70 and 84. They had mild to moderate level of hearing loss, which was the majority of older adults almost have. And they all had basically intact cognition. They had no substantial cognitive impairment. And when we started the study, they were recruited from 2 different populations. So at every site, there was a population of basically older adults who are already participating in something called the ERIC study, which is the Atherosclerosis Risk and Community Study. It's basically a study of older adults going on for many, over 30 years now. So these people have been long followed. They're a random sample of the population done from 30 years ago to basically look at cardiovascular health years ago, but they've still been followed to present day. So about a quarter of the sample came from the ERIC participants. The other 3/4 of the sample came from new healthy community volunteers who responded to advertisements about a healthy aging study and then joined the study as new participants. And when we started the study, the ERIC participants, we noticed on average, they were slightly older than the healthy volunteers. And they also had, in general, more risk factors for cognitive decline. On average, they had higher levels of high blood pressure and diabetes, slightly lower education, mainly because they were truly a random sample of the population from years ago, as opposed to, something we call the healthy volunteer effect. New healthy volunteers came in. But that's okay. So that's how we started the study. At the very beginning of the study, nearly 1,000 people, and they were randomized, flip of a coin. Basically, half got best practices hearing intervention, basically meeting with an audiologist over 4 sessions, getting hearing aids, everything to support their hearing and communication needs. The other half got randomized to basically a health education control intervention. So basically meeting with a health educator, going over topics that are critical for healthy aging, like nutrition, vaccinations, things like that. So everyone had the same amount of exposure to study personnel. Everyone was then followed for 3 years with every 6-month visits, where basically they would get their cognition assessed, their thinking and memory goes assessed with a standardized battery of thinking and memory tasks, all of which basically, many of them didn't even have any hearing component to it. So basically it wasn't that people did poorly or worse because they had hearing aids on. These are all basically essentially more or less non-auditory cognitive tests. The last 3-year visit was the very end of last year. We've just finished analyzing the data. These have been now obviously published in The Lancet. And what we found was really actually sort of unanticipated in a way, but also makes sense in a way now, 2020 hindsight. And basically the results are like this. After 3 years, if we look at the entire group of 1,000 people together, we basically saw that people who got the hearing intervention, their basic rate of 3-year cognitive change was basically no different than people who got the control intervention. So it's like, oh, geez, okay, I guess it didn't do much. But the story deepens, though, because one pre-planned analysis had always been planned from the very get-go was also do the analysis separately within the group from ERIC, the older adults who represent a random sample of the population, versus the other people, the 3/4 people who came from the healthy community volunteers. And when we looked at the groups separately, we saw something really different. And basically what you saw is a group of ERIC participants, even though there were only about 240 of them, we saw there was a really strong effect of hearing intervention reducing cognitive decline, nearly essentially by half. So basically people who had the hearing intervention basically had half the rate of cognitive change over 3 years than people who were in the control group. In contrast, in the de novo, basically the new healthy community volunteers, we saw the hearing intervention essentially didn't do much. It basically had the same rate of cognitive change as those who were in the control group. So it's, you're like, well, why? Why is this? One of the key reasons we're understanding now in 2020 hindsight is this: if you look at the rate of cognitive change decline in the participants from ERIC, there was basically they had almost nearly a threefold faster rate of cognitive change over 3 years compared to people from the healthy community volunteers. And again, that makes sense. They were slightly older. They had more risk factors for cognitive decline, which is why they had a faster rate of cognitive decline. So the reason why we're seeing such a big difference, where we saw a huge reduction in cognitive decline with the hearing intervention ERIC group versus the other group, is because the ERIC group actually had cognitive decline, namely in the healthy community volunteers who didn't really have much cognitive change at all. It's really hard for a hearing intervention to slow something down that's already really, really slow. Whereas in the ERIC group had a much faster rate of cognitive decline. There was actually something to slow down per se. So the results make complete sense in 2020 hindsight now, and I can't say we fully anticipated it, though it is something we always planned for. We always thought they might be different. We just didn't realize how different until we finished all the analyses.
Mm-hmm. So this means that if I have risk factors for cognitive decline above and beyond being older, that this hearing intervention could really help.
Yeah, the important thing here about, I think when people get hearing intervention, get hearing treated, yes, there's always this, I would say, theoretical possibility. It may really help, support cognitive function over the long term. That's always the goal. The more important thing, I think, even think about when you get hearing intervention, is the more proximal effects. And why do we do it? It enhances our ability to communicate, to socially engage, and things like that. So I think for anybody, absolutely, hearing intervention, I think it's been shown, and the Chief trial shows it too, it can definitely improve cognitive benefit. It can definitely improve communication benefits, help you socially engage more, right? It's just if you're expecting to have quote unquote cognitive benefits within just a 3-year period, if you're really cognitively healthy, you're not going to see cognitive benefits because you're going to be fine regardless of what you do, right? Mm-hmm. So I think the key thing to think about is, I think, hearing intervention is one of those things is that it comes at no risk per se, right? We're not talking about risky intervention. So I think that really the clinical takeaway from this, from my point of my perspective, such as being as the other job I wear as besides a researcher is I'm an ENT surgeon, is that I think for almost anyone now with hearing loss, older adult, it's definitely something you should get your hearing checked, and then if there are any hearing issues to be addressed, absolutely address it. There's really no downside to it, right? Can it help your cognition in the short term? If you're completely a cognitively healthy person, I would say no, it's not going to help your cognition in 3 years, and there's really nothing to help. You're doing fine, but it can help other things, and maybe in the longer term, absolutely, right? And that longer term study for the really healthy people is what we're continuing to do over the next several years as well.
So my father is going to be 80 next year, and he has hearing loss that he refuses to get treated, refuses to acknowledge. It seems like a perfect study to show him, to convince him that it's time for the hearing aids.
Yeah, I think that's absolutely right, Stephanie. And I think so many people have a story like that, where someone they know, a friend, a parent, just doesn't want to do anything about it because, first and foremost, people think it's not that important, right? It's just, I'm getting a little old. I hear fine. It's just my wife mumbling at me at the time, right? It's not my problem. It's someone mumbling. But that's what hearing loss is.
That's exactly what he says.
Yeah, right. But, and I think that's what hearing loss is. When you have hearing loss, it's not so much you can't hear, right? It's more that things don't sound clear, right? And the reason for that, when you have a hearing loss, what it basically means is your ear is no longer sending sounds clearly to your brain. So it sounds like everyone's mumbling at you, in which case it's really easy to quote unquote, blame the other person. It's not me. It's just these teenagers mumbling all the time, right? But that is what hearing loss is. That's how it's experienced. I think the key thing, for folks like your father and everyone else out there is realizing that, well, to recognize that is what hearing loss is. It sounds like people are mumbling at you. It's not them. It actually is your ears, right? It's not like the source is you in many ways. And then from there, understanding that there's really, I think, very strong, compelling evidence now suggesting that treating hearing loss can really have cascading effects, even on cognitive health in particular.
These results are really impressive. I know we recently talked about the fact that there's over-the-counter hearing aids available now. Is this another argument for why Medicare should start covering them?
Oh, we certainly hope so, Stephanie. And I think the reason for that is if you look at what the intervention is per se in this ACHIEVE trial, yes, hearing aids are without a doubt a part of it. But the other big part of it is the audiologist who's there to help the person support their use of devices, to basically convince people like your father that the hearing aids can help them, to show them how to use it, to customize it for their lifestyle. And listen, not everyone needs that level of service. For example, if you're, let's say, just a super savvy 65-year-old, you use a smartphone, everything else, you may not need that level of service. But for a lot of people in their 70s to 80s who may not be as familiar with technology, that those audiological support services are so key. So the beauty of OTC hearing aids, which was a huge win for the country and for consumers, is that it's a huge win overall, but it comes with a caveat. And the caveat is this, is that while soon, the next 1 or 2 years, the market matures, we're going to have, I think, really phenomenal, much lower cost hearing aids on the market. There are many people who will still need the services of an audiologist to help them even use those devices to its fullest. So, when we last spoke, we were really pushing hard, and we got close with the Medicare legislation a few years ago, back from 2021 now, including a hearing aid benefit. And what that would have done is Medicare would have begun covering audiological services for everybody who needed them. And then if you had a hearing loss that was in the mild to moderate range where you could benefit from OTC hearing aid, Medicare wouldn't cover your hearing aid. You get your hearing aid yourself, but if you need services, you go see an audiologist. And then if your hearing loss is on the more severe end, where an OTC hearing aid wouldn't help, and you need a prescription hearing aid, then Medicare would step in at that point. So I think that the important thing is really that the ACHIEVE trial, this wonderful hearing intervention we gave in the trial, the bitter irony of, again, from a policy-based perspective, is this: as promising this trial was, as impactful it was, the bitter paradox, bitter irony is that intervention we delivered in ACHIEVE would not be covered by insurance right now in the United States as it is. And that really is sort of the tragedy and the whole thing about this. And that's something we hope to change. I think that's really the next policy step. Now that we have OTC hearing aids are cheaper. The next thing we need is to ensure that the services that seniors would need to benefit fully from OTC or prescription hearing aids, that those become available. Really, honestly, not only to benefit, let's say, just, our seniors out there, but to really benefit society. If we think reducing cognitive decline could, on the longer term, actually reduce rates of dementia, which actually was a logical extension, that is a really compelling, just, how do you put it, like money in the bank financial argument for Medicare to cover. And that's, I acknowledge that's important beyond just the feel good, it's the right thing to do thing. It's really both now.
Mm-hmm. And what is the link between hearing loss and cognitive decline? Is it that I can't hear, so I tune out, and so that's why my memory starts to go?
Yeah, so there are three major theories now. The first one is a little bit what you get at. It's basically the idea that when you have hearing loss, some people may not be as socially engaged. You may become more lonely, maybe become withdrawn. And that's important because one thing we definitely know about risk of dementia and cognitive decline is that if people aren't constantly, or let's say, if people don't remain engaged with cognitively stimulating activities, right, meaning going out and engaging and trying new things, that's not good for the brain, right? So just the fact of hearing loss affecting your social engagement and maybe even stress per se, that can definitely have a deleterious effect. So that's one mechanism. There are two others actually too, and these aren't mutually exclusive. It's like a combination of all three. The other one gets at what we spoke about before. Basically, when you have a hearing loss, it basically means your brain is constantly not getting a clear sound from your ear. And the way the brain compensates for that is the brain literally, you can actually measure this in functional imaging MRI studies, is the brain dedicates more brain power, more brain resources per se to dealing with that much more degraded sound. And that comes at a cost, we think now. The brain is constantly reallocating resources helping with hearing. And that comes at the expense of our thinking and memory abilities, or protecting or helping protect the brain against other pathology that can lead to dementia. So in that situation, this idea of cognitive load, it's not so much that hearing loss causes dementia, but hearing loss taxes the brain and leads to earlier exposure of dementia from other factors that can lead to dementia, right? That's called the cognitive load hypothesis. The last mechanism sounds related, but it's a little different. And it's the idea that hearing loss can actually directly have negative effects on the brain's structural integrity. Basically, with constantly reduced auditory stimulation of parts of the brain, which is what happens with hearing loss, is that parts of the brain begin atrophying faster. And we actually see this both in human and animal studies nowadays. And that, you can imagine, a shrinking brain is not good for brain function. So I understand it's likely a combination of all three, either this idea of cognitive load and or direct sort of negative structural effects on the brain structural integrity, and or through social isolation. And, the reason why, Stephanie, those mechanisms are so important is that all three of those mechanisms suggest, in fact, that treating hearing loss, something as simple as using a hearing well, could directly modify or affect those pathways and reduce the risk of cognitive decline, right? Namely, you provide a clear auditory sound to the brain with a hearing aid. We certainly hope we're reducing any cognitive load on the brain. At the same time, we hope we're stimulating the brain more, obviously, with increased sound. And the whole reason we treat hearing loss is really to hopefully keep people engaged. So from a proof of concept perspective, we think hearing aids, hearing treatment could make a difference. And I think that's what we're seeing right now with the results of the ACHIEVE trial.
Franklin, thanks so much for joining me.
Absolutely. Thanks for having me, Stephanie.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmon. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.